Welcome to. Is working? Hello? Mic is not working.
We're good? Yeah.
It's okay? Hello?
Yeah. Yeah.
So, welcome to London Valves meeting, and we're very happy along with Dr. Christopher from Mount Sinai, Cedar Sinai, sorry, from US. I'm Professor Dr. Vivek Gupta, cardiologist in Delhi Apollo Hospital, and of course the London Valve meeting is one of the finest meetings for the valve. I just wanted to introduce myself. I work in Apollo Hospital Delhi, and I have the privilege of saying that I worked with Anna Krivier, the father of TAVI, who did the first TAVI in April 16, 2002, and I was working with him in Charles Nicolle Hospital, Delhi. Sorry, France. So let us start this rapid fire TAVI, and we have many speakers. We will have a TAVI in patient with cardiac shock. We will have a TAVI in pure AR. TAVI processes mismatch or something else. Then we'll have a tug of war during the valve-in-valve, which is very important. Charting a path, TAVI in a patient with challenging aortic conditions. We'll have frozen leaflets aggravated by post-dilatation. So let's start with the first talk, which is from Dr. Matthias Bunch, and he's going to Slovenia, very important country, and he's going to speak about patient processes mismatch or something else, PCI and valve-in-valve TAV after transaortic TAVR. So welcome Dr. Madzat to start your presentation, and very happy to have Slovenia talking about the technique which is now a revolutionary technique of transcatheter aortic valve implantation.
Okay, thank you for this kind introduction. This case is always a challenge to present in a way that the simplest thing is short time, and another way it's important that they are available even later, because now the audience is dispersed all around. So I would like to share with you a clinical case of 88 years old lady. She was treated 11 years ago with implantation of percutaneous aortic valve after surgery. After previous surgical revascularization. She had generalized arteriosclerosis, but what is very important is that she was Jehovah's Witness, so there were some problems with the classic surgery. So she was presented 11 years after implantation with severe aortic stenosis. You can see here the echo parameters with the mean gradient close to 40, reduced ejection fraction, the mildly reduced, and also some mitral regurgitation. So this is the CT scan. You can see here, you can appreciate here the anatomy, the position of the first implanted valve. But what was here also important that we found the bifurcation lesion from left main LAD circumflex. So we have to decide what to do, whether surgery. I mentioned that there was contraindication even 10 years before. Therefore, in TAVI team we decided to do first bifurcation stenting, and after that valve-in-valve implantation. You can appreciate here that the inner side of the degenerated valve, you can see in the between 6 and 12 hour big spot of this fibrosis, and this was also the reason why I picked for picking smaller valve. So this is how we proceed first with the PCI. Here is not the last scan with the final kissing, but the flow through the arteries was good. And this is how we performed the implantation. So we picked the smaller valve, 23. Usually we pick the same size of the valve of the valve that is degenerated. But here I showed what was the rationality to pick smaller valve. This valve was first implanted quite low, so in that time we were scared that this valve might migrate in the ventricle. So we decided in this implantation to go a little bit higher, but not too high, to avoid the neo-LVT or this big neoskirt formation. So here you can see the procedure. The first valve was really low, so we targeted a little bit higher implantation. And here is the final result. But 2 days later, 1 day later, we found that the gradients of the valve are quite high. You can see here the speed was 3.4 and surface area 1 square centimeters, and the mean gradient was close to 50, what was not good. And according to the calculations, functionally this should be a severe patient prosthesis mismatch. But we repeated the CT scan and noticed that the opening of the frame of the second valve is quite good. And after CT analysis, the leaflets of the valve were thickened. So there was clear leaflet thrombosis with the disturbance of the motion of the leaflet. So the first therapy was the introduction of the anticoagulation. Besides the antithrombotic treatment, so we have triple therapy for one month, and after that we rechecked the echo. We know what are the mechanisms, check the echo, and you can see here substantial reduction of the mean gradient to 19 millimeters mercury, and the function of the valve is much better. But the problem, as I mentioned earlier, is the implantation of a smaller valve. If we do this case again, I would probably put 26 with a little bit gentle inflation to obtain a little bit better gradients. Maybe the scar tissue that was engaged or caught between the both frames was the basis for this leaflet thrombosis because the opening of the inner frame was not complete. So now we are planning, now it's 6 months after the implantation, we are going to do another CT scan just for the follow-up and see what are the consequences of the treatment. So let me conclude, in case of this valve treatment is everyday practice for everybody because especially surgical valve are prone to degeneration, not so frequent the TAVI devices. And we should be aware what we are doing, and if we obtain a high gradient, we should be clear what is the mechanism. Usually is the thrombosis of the leaflet, but there may be also some other issues like under-expansion or malposition of the valve. So thank you for your attention.
You want to comment? Oh, thank you. Hello. Yeah, thanks for your presentation. We may not have too much discussion. I just wanted to know from myself, after how much time of your deployment, did both the valves were Edward valve or which one, what kind of valve did you put?
We implanted Mr. Sapiens spray valve into this old version of.
Okay, so how much time after the implantation you think the thrombosis happened? How much time?
On the second day.
Second day. And did you give some anticoagulation during the implantation? Of course.
It's not routine. It's not your routine procedure, but we are thinking about that in this particular.
So I think the learning from this message is that you have to be careful, especially when you are doing TAV and TAV. Then anticoagulation may be given during the time of procedure, which may not be so, unless it's contraindicated, which is normally not, because you already had a patient PCI or left main disease. I think it's a good case. We cannot have major discussion. We can go to the next presentation. You can announce.
Thank you. Okay, so we're going to revert back to the original running order now, and our next presenter is going to be Raja Ramesh Anakuvarapara from India. And he's going to tell us all about having a patient with cardiogenic shock. Welcome.
Good afternoon. Thanks for the TCR London Walls for giving me the opportunity. I'm presenting a case of TAVI in a patient with cardiogenic shock. So here is a 70 years male diabetic hypertension and positive history of CVA, presented with chest pain and NHA class 3 dyspnea. The initial ECG showing ST elevation in EC, anterior leads with LBBB and prolonged PR, echo showing EF of 35% with the recent wall motion abnormality in the anterior wall and severe aortic stenosis of P gradient of 80 and mean gradient of 40. And in view of ACS presentation and troponin being strong positive, first initially we thought of, we look at the coronaries and the coronary showing LED mid lesion of 80% with thrombosis. So as an ACS presentation, then we are in a dilemma whether to fix the coronary first or to address the valve first. So in view of ACS presentation, we have fixed the LED and then we thought of we'll do the TAVI after a week or two. So after a week again, he presented with an acute heart failure and cardiogenic shock, this time with metabolic acidosis. The EF further dropped to 25% and he developed severe PAH. Again, there was a discussion with the family whether to go ahead with TAVI immediately or not, as the son is staying away from him. So initially we stabilized with heart failure for 1 day and then we planned the TAVI. So this is the initial ECG showing some STs in anterior leads and initial mean gradient of 47 and mild MR and no TR. This is when the later a week when presented with the cardiogenic shock, we can see the EF further decreased and the gradient dropped down to 33, then a state of low flow, low gradient with LV dysfunction was erased and there is an increased degree of mitral regurgitation and tricuspid regurgitation and developed severe PAH. Then we thought of this is the time that we have to fix the region for cardiogenic shock is the aortic stenosis. So we thought of we'll do TAVI in this patient. So we went ahead with the three-dimensional analysis of the aortic root and femorals. The aortic annulus area of 432 with area derived diameter of 23 and perimeter derived diameter of 23.7 with the borderline right coronary it's 12.2 and good LCA height, and it's a bicuspid type 1B aortic valve with okay sinus of Valsalva and the axis, femoral axis being okay with 7 to 8 mm with 180-degree calcification at the just above the distal bifurcation. The procedural plan, initially we thought of we required the general anesthesia as the patient has severe LV dysfunction and PAH, but we end up doing under conscious sedation. The transfemoral route we have chosen the cerebral protection device as this patient has a past history of CVA and it's a bicuspid valve with calcium. We have not planned the pre-dilatation. We want to implant the valve as short time as possible when come out we have severe LV dysfunction. The coronary protection was not planned as the reasonable coronary heights. And the pacing by temporary pacing lead, by short runs of pacing at lower rate in view of the severe LV dysfunction. We are choosing a balloon expandable valve, my valve. And regarding the sizing, we have a luxury of this intermediate size valves in the Merrill my valve. So if you take the 24.5, then it's 9% oversize. That is an appropriate with the 400 mm, 400 calcium. So the placement of the sentinel device in the first figure, and then we cross the valve with the air catheter. And the third figure is showing the initial hemodynamics peak-to-peak gradient of around 40, and we position the valve 24.5 across the aortic valve, and we have deployed under rapid pacing the final aortogram showing no AR and the hemodynamics showing no gradient. So this is an echo after 1 month follow-up with a normal LV function, single-digit gradient, no TR, no PAH, and patient is doing fine. So the conclusions are that acute coronary syndrome can sometimes trigger cardiogenic shock in a stable patient. The timing of the coronary intervention is critical in relation to the valve intervention, and there is a debate which one should do first. And the shock due to aortic stenosis can only be treated by the valve replacement, and TAVI is safe and effective treatment for aortic valve stenosis prevented with cardiogenic shock. A patient who survived the first 30 days of the TAVI has similar mortality than those who are not in the cardiogenic shock during the time of the TAVI. So it seems a therapeutic option with the TAVI seems a therapeutic option with patient with cardiogenic shock and severe AS and degenerative aortic process in terms of both safety and efficacy at early and long-term follow-up, as evidenced by the shock TAVI shock registry from 2020. Thank you.
Excellent, thank you. Challenging case of a patient presented with an ACS, poor LV function, and severe/critical aortic stenosis. So, you decided to delay the treatment of the aortic stenosis after the infarct, and the patient was well at that time, presumably. Would you change your strategy in a similar patient presenting in the same way?
Yeah, retrospectively thinking that TAVI could have been done in the first, because the reason for cardiogenic shock is the aortic stenosis, is not the coronary, but we were misled by the STs, the strong troponin and the presentation in the chest pain. We thought of doing the coronary is then appropriate, but retrospectively when I'm thinking back at this case, I thought of I could have done the TAVI first or at the same time.
Just a quick comment. Did you check the coronary while you were doing the patient had gone to coronary cardiogenic shock? Did you check the coronary at that time? I think it did not.
No, during this valve intervention time, we have not checked with the coronary.
What could have been the reason for this acute deterioration? Because he was rather stable after the procedure.
He was stable a week and then he developed. The reason being the aortic stenosis only.
Okay, okay. Just want to tell you that first case before done by Alak Rebe was also in cardiogenic shock. And he did through the transeptal technique. So cardiogenic shock with AS becomes a prime indication for aortic valve TAVI rather than SAVR. So thank you very much. A good case, I think, to learning, and we move on to second case. The second will be, third will be.
Thank you.
Thank you. Well done again. So we're going to move on now. The next case is regarding TAVI and pure aortic regurgitation, also in a patient with cardiogenic shock. Presented as Ilgar Taharoklu from Azerbaijan. Who's hopefully here. Okay, maybe we'll give Ilgar some time to arrive, and perhaps we move on to our next case. Is Ariogu Alusa to step forward. Welcome. So Adeoki's from UK, and you're going to tell us about tug of war during a valve and valve tap.
Thank you for inviting me to present this interesting case to us. I do want to acknowledge the support of my consultant colleagues from the level of in the UK. So the title is Tug of War during Valve of TAVI. There's now a conflict of interest. This is a 71-year-old lady who had TAVI elected in August. She had a recklessness and the valve replacement between 2018. She's contacted She presented to hospital in March 2020. We walked up towards TAVI. Blood was okay, and institutional signs were LVH. She had a TOE showed severe aortic stenosis, preserved by vascular function. We had a CT measurement analysis, which was on that area of 343 to 66. Coronary height were very low. The VTs on the left was 6, and the right was 4.2. That was a CT measurement. So the indication was symptomatic severe due to coronary height, arteries up front, using an EGR4 on the right guide and an EBU3 on the left, coronary right in situ. And the plan was to do pre-dilation, and then if this occluded the coronary arteries, then we'll end up using a snorkel or Jimmy stenting. Our valve chosen valve was apparently in this situation, small size, and this is where the angiogram and the setup shot on the first left, and then if you look at the fourth video on the right upper area, that was where we had really struggled to maintain coaxiality and position of the valve. It took almost 5 minutes, and that required retracting the wire, pushing forward, pushing the wire back into RV, retracting, and it was really difficult because of small space. And eventually we were able to get into position in the left picture below on the left side, and then the middle one was step 1, and on the right middle one was step 2, and eventually we deployed the valve. The peak to peak before dilation was 80.5. We used the predilation with 18 millimeter Lucas balloon. And at the end of the procedure, the peak to peak was 30.99. Coronaries were patent at the end of the valve procedure, and we noticed a filling defect on the right side of the aorta due to the stabilization of arch, also the focal dissection. This was confirmed on CT, but the patient was fully stable. And as you can see on this, that was the dissection there, and confirmed the CT. Patient was fully stable. We controlled our blood pressure by adding an extra blood pressure tablet using amlodipine, and then she was kept here for about 3 days and got discharged home, fit and well. Patient is doing well with those symptoms, and discharge echo shows satisfactory elbow function with well normal functioning prosthetic valve, and there was no pericardial effusion. The learning point is valve TAVI using a self-expanding platform is safe, and however it may present with some challenges, like in our case with small size and small space. Knowing how to overcome these challenges is extremely crucial, and understanding the way the valve platform works is very important. In this case, we chose an apparat because we wanted an top-down deployment, which allowed no enablers to push it down to finally deploy the valve safely. And this is what we achieved in this case. Thank you.
It's a great case. Okay, so valve and valve, small anatomy, low coronaries, and difficulty delivering. So what do you think the mechanism of the aortic dissection was?
So the stabilization of arch, as you can see, was impinging on the aorta, so that caused the dissection. So, yeah, if you look at it on this, around this area during the step 1, so due to the struggle on the upper area here, we had to now go with step 1 deployment to allow us to push it further. And when the stabilization arch came out there, here, you will notice that's where the dissection came from because of the stabilization arch.
Okay, great. And so you had stents in the coronaries, but you didn't deploy it, is that right? 'Cause you were
No,
out.
we didn't put a stent. We did a balloon predilation first, and the coronaries were open.
Right.
So we didn't.
So that was your strategy, assess at that time
Yeah.
and then remove the potential.
Yeah.
Okay, well, we've got a bit of time for comments from the audience. There must be some comments on this case. Does anyone have a question or a comment right away?
Thank you very much. When you notice that there is this tension to the lateral wall of the aorta, don't you just pull the valve and then you do the predilatation with the more proper predilatation? Maybe this complication would be preventable if you did one more predilatation. What do you think of that?
That's a very good question. However, in this valve platform, once it gets into the body, you have to deploy it. So if it was to be Medtronic or any other platform, yes, you can recapture and then do another predilation. But in this situation, you have to deploy it. So we went ahead to deploy it. I think in learning retrospect, using a London quiz wire might have given a bit of support. I think that might have given a better support than using a Safari wire.
What was your balloon? How big was
That
your
was an 18 millimeter.
And it came up?
Yeah, it came up quite well. Because I'll play that for you.
Yeah. So, hello. Regarding that decision part, the last shot, can we have the last post-deployment? Everything was fine at that time?
Yes, everything was fine. We can see the section there as well. This was deployment picture.
You have the follow-up after 1 month or something?
Yeah, we saw the patient 6 weeks later in TAVI clinic. Patient was doing well.
Absolutely. No, dissection sealed off.
Yeah.
Completely.
Yeah.
Thank you very much. I think it was a great case to learn and tug of war, up and down, top. What do you think this should be the final? Down and up or up and down?
Well, I think it depends on your expertise.
Okay, we
really.
can move on to the next topic, and that will
Thank
be.
you.
You save the life of the patient, and next is charting a path. TAVI in a patient with which one?
So that's right, yeah, charting a path, having the patient with challenging aortic conditions from
Dr. Amir Elak Marsh from
UK.
From UK.
Also.
Oh, this is your home,
Welcome.
You are talking to the. This is the host, possibly the host.
Hello, good afternoon, dear colleagues. I am Amir. I am one of the cardiology trainees in Bristol, and today I am sharing with you the story of a lady and how we managed to empower this strong lady after being disempowered. So this, my lady here, she's 73-year-old, presented with symptoms of heart failure. She's hypertensive, type 2 diabetes, and CKD, history of breast cancer, colon cancer, bilateral knee replacement, very large para-umbilical hernia, and she's atrial fibrillation on edoxaban. And her echo showed a critical aortic stenosis with a valve area of 0.46, DBI of 0.16, and the mean gradient of 72. So can you please raise your hands if you think an aortic intervention of this lady is an easy option? So as we can see here, she is quite kyphoscoliotic, quite multimorbid. Anyone thinks it's like surgical or TAVI intervention is an easy option, this lady? But because she experienced very good life before her heart starts to fail, we took.
Is she the same lady or somebody else? Is she the same lady?
She was similar. She's not exactly the same lady, but very similar. So we took the initiative. We tried to help her. We did the CT TAVI, and as you can see on the left-hand side, she got a relatively narrow iliac arteries, very tortuous iliofemoral axis, very distorted aortic anatomy, and there's also quite severe calcification in her aortic valve leaflets extending into the LVOT. The average diameter was 23 millimeters of the aortic annulus with area of 4 centimeters square and the perimeter of 74 millimeters. So the challenges in this case were severe subannular calcifications, severe kyphoscoliosis distorting the aortic anatomy, and the restrictive lung physiology because of kyphoscoliosis and a very large hernia. So we decided to take her to the lab by femoral access, and we used the AL1 to pass an Inouye wire into the LV. And we used the Sapien 3 Ultra valve using a commander delivery system. And we managed to get the nose cone into the LV, but the valve itself didn't cross through the aortic annulus. And as you can see here, all the pushing force is dissipated laterally instead of forward on the right-hand side. So we escalated our technique, and we exchanged the Inouye wire to an extra stiff Linderquist wire to give a better support for the valve. And then again we tried to insert the valve into the annulus, but again it didn't manage to cross into the annulus. So we went upwards to the next step, which is doing a balloon cushioning technique by doing a slight inflation of the valve balloon. And as you can see here, finally with the balloon cushioning we managed to cross the valve into the aortic annulus. And then the valve was successfully deployed into the annulus, and we got very good final results with only mild paravalvular leak. This lady, she had an echo next day. There was only confirmed stable TAVI valve, mild paravalvular leak, and she was discharged on day 2, resumed her eloxaban, and we really changed her features and her lifestyle after the procedure. So learning points here: first, be careful about kyphoscoliosis because it's a big challenge. It distorts the aortic anatomy. We need to have a stepwise approach of escalation in cases with difficult valve delivery. Aortic tortuosity can be mitigated using extra stiff wires like the Linderquist, and the balloon cushioning technique also can help deliver the balloon expandable valves in people with difficult valve delivery. Thank you very much for your attention.
I think it's a great case, but is it only the kyphoscoliosis which caused the problem, or aortic tortuosity, or both?
I think the kyphoscoliosis has contributed a lot to the aortic tortuosity, and this also has affected the
But she's just 73. I was surprised. A 73 young age for the Europeans. She had so many diseases, of course.
Yeah.
But why kyphoscoliosis? I mean, any idea? No.
So it's a degenerative. It's a degenerative kyphoscoliosis.
Any question from the audience? Yes.
Excellent case. What is the next step if the trick of the balloon didn't work? I think it will be difficult to get the valve outside this lady if the balloon inflated laterally. So, do you have any expectation for next step?
He also asked, suppose it would not have been happened.
Yeah.
Would you have aborted the procedure, or should you have gone for a... Do you think that balloon expandable versus self-expanding, which would have been easier in this case? Just for my knowledge and comments. Do you have an idea about this patient? Or both will have a similar challenge?
But no, I'm not sure if the self-expanding will be an easier option this lady.
I think the best what he did was changing the wires and all. Yeah, another comment is
with another wire in the LV can facilitate the crossing with the valve.
Yeah.
Just a quick...
Just a short comment from a surgeon. What happened to transapical procedures?
So I think that this lady was discussed in the MDT and the heart team MDT, and the transapical was not an first line option for this lady. The decision was for transfemoral approach. I mean, it could be an option if we didn't manage to deliver the valve through the transfemoral approach. But
could have been. It's actually a very good comment. In case it would have failed, the transapical would have been a better option than to changing the valve to the self-expanding. It's a very good comment from the surgeon.
Another comment.
I'm not familiar with balloon cushion technique. How do you perform it? How much do you inflate?
Yeah, so I have my mentor here. Nick is my mentor. He's my supervisor. So I would leave this question for him.
Thanks, Amir. With regards to inflation, you normally go up to 1 or 2 atmospheres on the balloon cushion so that you sort of capture the annulus and then push the system forward. Now, coming back to the other question which was asked, what would have happened if this technique would have failed? You puncture on the contralateral side, cross with another sort of wire, and then do a simultaneous inflation with the balloon and try and push the balloon, the valve at the same time as you deflate the balloon on the contralateral side. That's kind of would be the next step in this situation.
Yes, something what we do for the coronaries way when we have a calcified areas and then okay. Thank you very much. I think we finish off this discussion and we go on to the next presentation, which is thank you very much. Good case. Which hospital you are? Bristol. You said.
Bristol, yeah, Bristol.
How far from London?
It's 2 hours, 2.5 hours.
Okay, so you can plan for the next tour.
Brilliant. Okay, moving swiftly on. The next presentation is going to be from Yasser Sedek, and the case is regarding frozen leaflets aggravated by post-dilatation.
Hello everyone. My patient, 92 years old lady, non-hypertensive, occasional alcohol user, mild dyspnea was only her complaint. She had severe aortic stenosis and we decided to do for her TAVI. And as you can see here, his perimeter is 68, so the decision to go for accurate neo valve, small valve. And it was ordinary TAVI, crossing redilatation, which is mandatory in this platform. And this is a small accurate neo valve. And final release. And we here found that the valve not deployed well, so vasodilatation was done using 20 millimeter balloon, and with that vasodilatation, and the patient arrested. The CPR was done for only 3 minutes, and we thought that this patient had severe infusion, but not. And she had severe myocardial depression with severe aortic regurgitation. So we did another vasodilatation with 22 millimeter balloon, as you can see here, but still no improvement. So the patient didn't improve, and she was on high dose of nootropic support and immediately ventilated. Safari wire moved to and fro in the LV, but no improvement. So let's remove Safari from the LV cavity, and finally it worked. No aortic regurg and hemodynamics dramatically improved. So a stuck leaflet and the frozen cusps are reported complications following transcatheter aortic valve implantation. These complications are rare but can drastically change hemodynamics and be potentially life-threatening. Thus, their awareness during TAVI is indispensable. And for my knowledge, this is the first case of frozen valve after accurate neo. I searched, I didn't find anything reported. So this is the final result, and the patient dramatically improved after that trick. We removed the Safari wire from the LV cavity. So always be prepared for surprises in the cath lab. Simple solution might save the day. Thank you.
The selection cases we've had. Okay, so Professor Gupta, have you seen a frozen leaflet before? Shall we open it up to the audience? Any comments or questions?
Is it speculation that it's a frozen leaflet, or because if you have a TE after the patient arrested, you would know exactly that the leaflet is not moving, and you would know, and then you would report the case as that this is the case, because you can tell by the safari wire that it could be that pinching one of the leaflet causing the mitral valve to sitting with the anterior leaflet of the mitral valve. There is too many variables that can cause the patient to arrest at that particular time. So without having an imaging, you cannot tell for sure that this is the diagnosis that you claim is right.
As I mentioned, I did transthoracic echo, not TAVI, and there is no time for translate, but you are right.
But did you do transthoracic TAVI? You had
Yeah, I did. I thought that is severe
this is a problem with the accurate neo more because we have never heard about this in AdWords or any other level. Is something related to this new valve, accurate neo?
No, I think as you mentioned, the safari wire frozen the leaflets after post dilatation. With the patient, she was okay. After post dilatation, severe aortic regurg arrested. So I saw a lot of things that she had annular rupture or something like that. But it was for frozen leaflets. After removal of safari wire, the patient dramatically improved.
So it was just a chance you removed it, or you thought it is better to remove it now and let's see?
Yeah.
This idea came to your mind?
What?
I mean, it was chance removal or it was actually deliberate removal?
Yeah.
I think it's a good point to learn, and every case is a learning. You see, science is evolving. When we did the first TAVI in 2002 and then now 2024, 22 years have passed, so there have been a lot of different. I think this was a great session. I don't know how many of you attended the 20th year of TAVI celebration in Rouen and Charles Leclerc Hospital. Did you go there? Because 20th year of TAVI celebration was celebrated in 2022, and that was a great moment when everybody, including all the big people, including Jean Fajade, Patrick Saraz, and many all the Welsh people, they came and attended the program done by Dr. Alan Crebier. I think I just before finishing this, I want to give the tribute to my mentor, Professor Alan Crebier, who is unfortunately no more with us. He had a sudden cardiac death, very unfortunate, and he was all right till the afternoon, and suddenly he was found that he had a stent, but we never expected this to happen. So thank you very much for all of you for a good audience, and it was a great learning for all the cases. And the last comment from Christoph, you want to give something?
Nothing further from me. Thanks everyone for all your questions and comments and your engagement, and thanks to all our speakers.
But again, thank you so much for coming, and I thank my friend Bernard Prendergast who has organized this meeting along with this. Earlier it was Martin Thomas who was used to organizing this meeting, and he was part of our Indo-European course of revascularization which we did in 2008. At that time it was in Thomas Hospital. So all those Britishers who know them, and I really thank once again the organizers for putting this program. And again I'm remembering my mentor, Professor Alan Crebier, during this meeting. Because of him the TAVI is there, you know this? And when I was working with him, just to share with you with Christoph, that in 96, 97, he was driving a car. I was sitting as a fellow. He said, Vivek, I have an idea in my mind. I would like to do non-surgical valve replacement. I said, what? Nobody thought, 97 I'm talking. And then the idea was going on, and he did the prototype. And I want to tell you one more thing. A lot of people might not know through this forum. Medtronic, Edwards, all these two companies rejected the idea completely. And they said, this is a crazy idea, forget it. And they not only they discouraged, but they said that they will not sponsor this hypothetical possibility. And the surgeon said, no, not possible. And finally they made a company with the help of Martin Leon in the US. And then they could do this prototype. Israel, one of the engineers from Israel made a prototype, and the first case was done April 16, 2002. And after that, that was transeptal case. They did it from the femoral vein, groin, and then going to the right atrium to left atrium to mitral valve, and they put it. After that, lot of research happened in the partner 1, partner 2, partner 3 trials all over the world. Now this has become almost every cath lab is doing the case. So more than 1.6 million cases have been done worldwide, and we are still learning because this is still a challenging thing. The same thing what happened with the coronary stent done by Sigvard in 1987. The same now with 2002 started, now 2024. But we're still learning because every case is different. With the aging population, we have more and more degenerative aortic stenosis, and therefore we have to be very cautious. No mortality. We don't want any mortality. In any case, of course, patient comes for the life. We don't want to take away the life. That's why the purpose of these London Valve meeting or any other meeting, to learn and to educate. This is the basic theme of Neuro PCR, and it's the theme for, of course, London Valve. Thank you very much. Thank you very much for this program.
Thank you very much.
I will talk.